Okay, can you hear me now?
Yes, yes, perfect. No.
Okay, so it's a pleasure meeting you all. I would like to convey my greetings from Athens, and I would like to wholeheartedly thank Professor Xendios Kalagos and his wife Natalia for having provided me this great invitation to be part of this symposium. I'm a public health physician by training, and I work also on genomics. I'm currently at the National Public Health Organization in Greece, where there's a small focus on congenital disorders as well. So the topic I'm going to present you is titled Genomics in Pediatric Cardiology, Bridging Research and Humanitarian Care. And I will now try to share. So I know that genetics, and especially genomics, is quite complicated for someone who is not working in the field. So I will try to keep it as simple as possible. Just in advance, what genomics, the genetics relates to specific genes, whereas genomics relates to the whole genome. So let's see, what are the genetic risk factors and prevalence of the congenital heart diseases? So while the risk...
Sorry for interrupting. We didn't get to the next slide. You have to click on, I believe.
It is indeed higher in first degree relatives, which is an indication of a potential genetic component for congenital heart disorders. Why should a public health physician...
Sorry, Alexis, we don't have the next slide.
Infectious cause of infant mortality first, and second, it raises an issue of screening, in particularly how fetal echocardiography could be applied at a population level. When it comes to genetics, most congenital heart disorders arise from multigene mutations.
Sorry for interrupting.
Makes the investigation...
Do you hear me?
Specific single gene causality quite complicated, and which reinforces the notion that heart disorders is not only an issue of genetics, but also of the congenital of the in utero environment. However, there are indeed some single gene or chromosomal abnormalities that exist relating to congenital heart diseases, and for which I'm going to talk you in a couple of minutes. I must also mention that the severity varies because of potential modified genes, for example, that interact with the main genes, and other environmental factors. So, in a nutshell, what's the genetic contribution in pediatric cardiology? I think that both epidemiologists and clinicians, as well as surgeons, should keep in mind that about 1/3 of congenital heart disorders has to do with a genetic component. For example, there are chromosomal abnormalities such as trisomy 21 or 22q 11.2 deletion. There are also some single gene disorders related especially to mutations in genes that are transcription factors, but there are also some copy number variations that alter gene dosage. So what should we do? We should do genetic testing to allow risk stratification. In other words, to find out which patients and how much are at risk of having a genetic heart disorder, and how much is at risk. We should work on the prognosis and associated comorbidities, and we should also work out on family counseling, especially focusing on assessing the recurrence risk in future. And we also should keep in mind that even isolated cases, for example, cases that are no other family members implicated too, may also have a detectable variant. So this is a slide from a textbook showing how MATS is a risk for relatives or family members affected with congenital heart disorders. If you see the top of the table, when there's an isolated cases, then the risk of to relatives from the affected family member is no more than 5 to 6%. But when it comes to the one existing affected family member, then the risk raises to 10 or perhaps to even about 50%, where there are more than two affected first-degree relatives. So collectively, all these issues highlight the notion that clinical genetics, taking a medical history in the family, either by a cardiologist or even a genetic counselor or clinical geneticist, has its value when it comes to assessing the genetic contribution to congenital heart conditions. I'm keeping a bit busy on this issue, but I think it has its importance. So first of all, we should keep in mind that there are polygenic factors. Polygenic is a Greek word standing for multiple genes. That means that many genes contribute perhaps small effects. Where should we look at in the genome? Perhaps in variants that are of genes that are related into cardiac developmental pathways, in the same way, for example, that we would look to brain-related genes when it comes to neurological disorders. And we should also keep in mind that the little contribution of every gene could lead to a cumulative genetic burden. This can create also the idea of creating biobanks in countries like India, where there are multiple cases because of the high number of populations. Then we should also keep in mind that the genetic cause is identifiable in 20 or to 30% of the population. This means that we should insist on genetic analysis through several methods that molecular geneticists are familiar with and are applying. So we should not abandon, let's say, the battle of trying to identify a specific gene. We're talking about congenital heart diseases, and which means we're talking about the in utero environment, and that's something we have to keep in mind. We have to keep in mind, for instance, the effects of maternal health like diabetes or phenylketonuria, the effects of environmental exposure such as medications and infections, those of the placental function and nutrient delivery, as well as the epigenetic regulation. So for those not familiar with the term, epigenetics is like if for example, a book is the genome, then epigenetics is the little notes at the side of the book which instructs how it should be read. Then another question that rises in all countries and especially to resource poor settings is what's the role of the general physicians in pediatric cardiology besides congenital heart disorders? The general physician and the general pediatrician should always keep in mind the need to refer to cardiac, genetics, or lipid services, for example, when it comes to familial hypercholesterolemia, so that the diagnosis of the underlying cardiac condition should be enabled. At the same time, they should assist pediatric cardiologists in the family screening of high-risk individuals and implicate, for example, appropriate preventive strategies, and never forget to refer to relevant support groups, including patients advocacy group, as well as perform some testing. Now, more specifically about the gist of the molecular genetics approaches. It has become a gold standard that next generation sequencing, which means the sequencing of the whole genome, can enable the rapid identification of the genetic causes underlying congenital heart diseases. And in so doing, it assists in multi-system on identifying, multi-system or syndromic forms early, even when clinical signs are subtle. Importantly, the early recognition of syndromic congenital heart disorders, in particular through next-generation sequencing, is critical where clinical resources are limited, because it identifies recurrence risks for parents planning future pregnancies, and remarkably, it reduces diagnostic delay, which is often called the diagnostic odyssey, as well as misdiagnosis common in low resource regions. This will in turn allow a better planning of the surgeries that are expected to take place and the overall higher performance of the health system in pediatric hospitals. With your permission, I'm now going to dive deep into the embryology and cardiac development for you, just to have a bit of the idea. The critical windows of cardiac morphogenesis is important not only for the pediatric cardiologists but also for the OB-GYN expert who performs the fetal echocardiography. Just to keep in mind that the heart development begins in week 3 of embryogenesis, that the cardiac tube formation takes place in around 21st or 23rd day, and it leads to establishing the primitive heart structure. Then the cardiac looping and the development of the major vessels takes place in week 4. Then we will have the septation of the atria, the ventricles, and so on during week 4 and 8. This seems to be the most vulnerable period for congenital heart defects. So the earlier the screening is, the better the diagnosis can be made. So we should be very cautious about environmental and genetic disruptions during this window that can lead to congenital heart diseases. And by environmental, would not only refer we might also refer, for example, to potential medications of the pregnant women who might not be aware of her status until that week. I will be talking about specific groups of genetic contributions to congenital heart disorders. So this slide is just to remind you that our genetic material inside our cells is structured in around 23 chromosomes, 22 autosomal and 1 sex dependent. Men have X and Y and women have a double X chromosome, and this is karyotype. Chromosomal karyotype is the method to analyze that. And at the left side of the slide, you can see the now famous DNA double helix. We have 4 bases: adenine, thymine, guanine, and cytosine, and all these intertangents. For example, when at a specific point, if there's a specific mutation, and for example, adenine is replaced by guanine or cytosine or thymine, then this might lead to a defect in the protein, and this in turn might affect a specific organ development. Just to keep in mind some developmental syndromes that have a prominent features of congenital heart diseases. I'm sure you're all most familiar with Down syndrome, which is a trisomy 21, and it has a number of clinical features, including congenital heart disorders. Perhaps few of you might recall the Turner syndrome, which affects women, and it's the absence of one of the X chromosome. And there's always the Pateau and Edwards syndromes, whose fatality is high enough and does not allow survival of patients. Continuing on the same topic, so trisomy 21, the famous Down syndrome, creates a lot of atrioventricular canal defects, but is also associated with several other effects such as early congestive heart failure and atrial septal defect and so on. Then these are quite rare syndromes. It's just for your reference, like the Williams-Burn syndrome, where there is a supravalvular aortic stenosis due to defects in the elastin gene. The elastin gene leads to loss of arterial elasticity and to progressive arterial narrowing. And there is also the 22q 11.2 deletion syndrome, which leads mostly to tetralogy of Fallot because of defects in specific transcription factor. There is an excellent recent paper in Nature explaining how trisomy 21 can be used as an exemplar for studying congenital heart disorders. It seems like trisomy 21, in other words, the existence of an additional chromosome 21, leads to a shift of the atrioventricular cardiomyocytes towards a ventricular like identity. Now they've discovered a specific gene, HMGN1, that's a epigenetic regulator that can modify this reprogramming from atrioventricular to ventricular like cardiomyocytes. And what they aim to, the researchers aim to do is to apply the famous CRISPR-R methods, which are genome editing methods, in order to try to mimic these approaches and to correct the dosage of these genes in order to rescue septal and outflow tract effects. So in other words, these are excellent news highlighting how heart surgeons might collaborate in the future with clinical geneticists in order to create what's called a genetic surgery. I know I've kept you a lot busy with all this genetic material. I'll try to be as brief as possible. Transcription factors are those factors that get into the front of a gene and make the signal process for the gene to be expressed and to create RNA, which will in turn lead to protein. Just to keep in mind, there are four transcription factors like NKX2, 5A, GAT, A4, TBX1, and TBX5, all of which are implicated into cardiac development. And in turn, their variants are associated with atrial septal defects, for example, with endocardial calcium development, with disruptions leading to tetralogy fallow, or, for example, in the case of TBX syndrome, to mutations causing rare syndromes. What we need is a better variant interpretation. In other words, a better analysis of mutations. We need to know if these mutations are benign, pathogenic, or of uncertain significance. Why that's important? It's important because precision medicine depends on understanding what specific variants actually do and how can we do that? How can we improve it? We can improve it, for example, through CRISPR-R screening. That's, let's say, a molecular gene editing tool. We can improve it through artificial intelligence models, enabling a better analysis of protein structure, and we can also enable it through better clinical databases. What will be the overall outcome? The overall outcome would be more reliable diagnosis, fewer variants of undetermined significance, and more confident therapeutic decisions. We can also apply some dysmorphology scoring in order to predict genetic diagnosis even without syndromes. The 1-point scoring increase would lead to a 20% increase in diagnostic likelihood, especially if we combine it with other criteria, such as essential criteria for abnormalities. We should also keep in mind the principles of genetic counseling, the need for risk communication and autonomy to the patients in a way that's understandable to them, that supports their informed decision making without pressure, and that emphasizes patient autonomy. We should also focus on support in sudden cardiac death risk, so that we assist in interpreting cardiac-related genetic findings and in creating preventive strategies and monitoring. And last, we should be very careful about ethics, privacy, and discrimination, so that sensitive genetic information is protected. Possible discrimination risks are discussed, and ethical handling of results and family implications are made. So overall, genomics assists in bridging mechanistic understanding and compassionate global health. Genomics takes us from DNA to diagnosis in order to understand what genetically causes these disorders and enable genetic counseling. So better understanding through genomics overall leads to a better outcome. You might recall before that we've discussed about the small effects of a different number of genes. That's what's called a polygenic risk prediction. It's one of the most trendy topics in clinical genetics. So it seems like that we should not rely on a specific gene, but rather find the cumulative contribution of many genetic variants. Why it matters? It matters because many people may have thousands of variants, each of which exercise a small effect. So by creating this accumulative score, which is called polygenic risk score, then we will have a better idea on stratifying patients. There are quite a number of challenges in achieving that at the clinical level. You can see them at the left bottom of the figure. I don't want to get you into details, but once we advance to do so, we will be able to drag much more information through large population biobanks, through improved statistical models, and through reducing biases from appropriate mathematical approaches. So when it comes to clinical level of congenital heart diseases, genetics can assist in both clinical care support, follow-up, and planning. Having an early diagnosis can provide us clues on which people would need surgery or catheter interventions in the first year. Follow-up can be enabled by coordinated genetics, cardiac and clinical care, and family planning could be certainly supported by genetic evaluation, which assists in informed reproductive decisions. So, being a pleasure to talk to India, we should always keep in mind scalable tools for low resource regions. Most genomic tools indeed have been developed for high-income settings, so the need is to create solutions that work where resources are limited, financially or in workforce capacity. That is going to have an impact on achieving global equity in genomic medicine, on improving disease surveillance, and of having a better representation of diverse populations. There are different examples of scalable approaches. For example, nanopore sequencing is an approach that can be in the field. Cloud-based solutions can assist in having less computers in the field. Artificial intelligence automated tools can assist in simplifying the genomic results, especially when it's coupled to training people to develop a genomic expertise in the region. So that's how we can achieve a higher rates of global equity in genomic medicine, better results of disease surveillance, and better representations of many populations. And last but not least, when it comes to humanitarian application, genomics can assist in reducing diagnostic inaccuracy when access to genetic testing is better enabled. It can assist in early prenatal as well as postnatal interventions through early detection and treatment. In turn, it can assist in improving survival and quality of life by enhancing outcomes through timely and precise interventions. And overall, it can improve the survival and quality of life. So thank you for your attention.
Presentation, I can tell that I learned many things. Yes, it was a very nice overview on genomics, and especially genomics is now a new and continuing challenge, especially in the setting of congenital heart diseases. Now, do you believe that before each pregnancy we have, to have a detailed family genetic screening? And is it now systematically do the transcriptional changes screening?
Well, thank you, Professor Kalagot, for your question. There has been a lot of initiatives in Europe regarding whole genome newborn screening, which is expected to include assessing the risk for congenital heart disorders as well. So I think yes, at least in those environments, in those health systems that allow these opportunities to take place, I think prenatal genomic screening for congenital heart disorders will be important, yes.
Yes. And I suppose there is, some specific centers able to do this one. And I believe is out of the low and income countries policy to get access, to this kind of very specific centers. How, to make them, in the public health services, how we can include, this genetic centers in the public health policy of these countries. Is there, any initiative to introduce, this kind of services? Are you aware of that? Because really it's something that I'm discovering now with you.
Yes, thank you for your question. It's an excellent question. There have been some initiatives. I think I gave a talk last year for one of the Indians web channels regarding how to achieve genomics equity in India. I used to work for a Chinese research institution that was also a company, and their aim was to bring omics for all. There are several issues to achieve this. First of all, the cost of sequencing should become lower. Now, for example, it's not even affordable for a middle-class family, let's say in a middle-income country of Europe like Greece. Its cost is around, let's say, 1,000 to 1,500 euros. So it's quite difficult when it has to become a trio for the father, the mother, and the newborn. It goes to around 5,000 euros. So yes, one of the key issues is that the next generation sequencing approaches should have a lower pricing. That's the first issue. The second issue has to do with automating the bioinformatics pipelines. Right now, we need bioinformaticians and biostatisticians to analyze the results and find out what's the meaning of these mutations. Once AI enables to do that in a more automatic way, then things will become easier. I think these are the first parameters someone need to work on. And the third is to create what's called the genomic literacy. I mean, old school medical doctors might not be aware of the importance of genomic contribution to congenital health disorders. So it's important to try to educate at least the younger generation of medical students who will in turn become residents and fellows about the importance of genomics and how to try always to keep that aspect in mind.
Yes, thank you very much. Another question to Dr. Mentis? Yes, the final message, it means the cost is still very high and is not something easily accessible, for those countries.
That's right, yes.
Yes. Thank you very much, Dr. Mentis. Thank you.